continue with their annual report.
13 years ago I came, I ventilated around 80 cases for 1 year time. And today, in 2025, I have ventilated more than around 388 cases. That is 5 times more than what it was. On the other side, we cross total admissions into the ICU more than 2,000 last year itself. And now our number is 2,327, and the survival from the ventilators is 68%. And the mortality hasn't changed from last year to this year. So we are doing good, and in the coming this year probably we are a 25-bedded ICU and we are going to be 50-bedded ICU. So hopefully we will work hard and we will produce more results, and all the credit goes to every department and everyone work very hard, and we will work hard more in the coming future. Thank you.
Surgery started functioning in May 2016 with a single faculty member, that is myself, and is now into the 10th year now. It was a humble beginning with help and support from other departments like obstetrics and gynecology and the pediatrics department, who helped me in this journey from 2016 to 2025 with the NSU, PICU setups, and we have performed a total of 415 surgical procedures over this period and 0 mortality till now. These procedures support various complicated neonatal surgeries as well as reconstructive procedures in pediatric urology, pediatric GI surgery, and oncological procedures also. So coming to the previous, the statistics show around OP census of 407, inpatients were around 43, and total surgeries performed 39 in the last year. Regarding the academic activity, the Department of Pediatrics is involved in training of the postgraduates from surgery department who come on deputation to our department for a period of 1 month during the second year of training. And pediatric residents are also undergoing training regarding the pediatric surgery topics or the patients whenever the clinical meetings or in the interdepartmental meetings. We discuss these treatment and other management protocols with each other. Coming to the various conferences which I attended as a delegate and chaired some sessions in the state conference of IAPS in January 2025 at KIMS Hyderabad. After that, I have attended the PESICON conference, annual conference at Amrita Institute in Kochi in February 25, and SPUCON, that is Pediatric Urology Conference, National Conference at Coimbatore in September 2025. We had an interesting case, surgery which was done in my newborn period in the month of June 2025, which was accepted for e-poster presentation at APSC-Con at NRA Medical College. And our second year postgraduate, P. Navya, presented this poster, and it was she presented this paper on giant meconium pseudocyst, a rare condition. Thank you very much.
Good afternoon, everyone. DG sir and respected colleagues. This is regarding the academic activity of last year. Total OP was 594 and number of surgeries was 68. This is one of the publications from my side last year. High voltage contact electrical injury to the neck and subsequent delayed onset airway edema, a case report, which was published in Indian Journal of Critical Case Report last year. And this was the case. Direct contact to neck who developed delayed onset after 24 hours, delayed onset neck edema leading to stridor, and he was referred here after intubation. So he underwent multiple procedures for the neck defect. The last picture shows the final outcome. Pectoralis major flap was done for the cover of the neck wound. Thank you.
The statistics, we had outpatients of 1,460, inpatients of 237, number of surgeries is 99, deaths are 9. All these 9 are emergency and non-operative. No deaths from the 99 surgeries. These are the different variety of surgeries which we have done. Frontotemporal brain tumors, frontotemporal tumors. So out of which the endoscopic third ventriculostomy case, we did endoscopy for the first time here. We don't have endoscopy equipment. It's a borrowed equipment. So others are collared system, third ventricle. These are the cranial surgeries. These are the cervical surgeries. Cervical anterior approach, anterior discectomies, corpectomies. Cervical posterior approach, lateral mass and facet screw fixations. Spinal tumors, we had 4 intradural extramedullary tumors, thoracic fixations, CV junction surgeries. Lumbar spine, as usual, constitutes the maximum number, 36 surgeries. So what I would like to say is a lot of variety in neurosurgery for the general surgery residents. One need to acquire a lot of skill in various types of surgeries. This is only 50% of the, still we have a lot of surgery, at least 40 different varieties of surgeries. One need to acquire skill. Takes time. After MCH, it takes at least 3 to 7 years. One needs to work in high volume centers so that performing surgeries without complications is not a small issue. Fortunately, all these patients did well, but one patient sustained fulminant meningitis, and that patient left LAMA, so that is not there yet. Most likely she would have died. So I would say mortality is 1%. She would have gone home and most likely she would have died. Recovered. It is not because of surgical problem, but because of fulminant meningitis. And after that case, I think with our anesthesia department and superintendents have done revamp of the OT, and there are no more surgical site infections in all the cases. All of them did well. So these are the statistics month-wise. The increase in, as compared to last year, outpatients is 59% or 60%, inpatients are same, and surgeries, the increase is 35% as compared to last year. But the previous year, the volumes are much more than this year, I mean the 25, when Dr. Sudhir was there. So we haven't reached Sudhir's level. Sudhir has did 130 cases. So, per year, that year, last year there was a dip anyway. This year definitely will cross. We have one more colleague also. We don't have endoscopy equipment, sir. No, not yet. We are asking. We have asked it, sir. Yes, sir. Yes, sir.
We never said we will not give.
Yes, sir. Yes,
Any instrument.
Yes, sir.
If it's going in crores also, we are doing that.
Yes, sir.
So,
No, actually, I have asked, did not insist because I didn't know how much is the volume. And the amount which we spend, actually, at least if there is 1 to 2 cases per month. So whether I wanted to assess whether we have the required volume or not. So
we cannot say that we don't have equipment.
yes,
It has to be there.
yes, sir.
Whether we use it.
Fine, it's good for us. We'll definitely forward the request, sir.
Absolutely.
Thank you, sir. So these are the 3 interesting cases which we presented in the Wednesday meetings. Department, there was no neurosurgery wing in the central library. So we have started that, and 3 books have been allotted. There was only a departmental library. So for the PGs and UGs may not have access. Some UGs or PGs, if they want to read more, they don't have access. So we have started the wing in the library. So this is ongoing study. It's a preoperative thoracic side spine marker. We have got the ethics committee approval. So one senior resident who was working with us got selected into MCH neurosurgery program. One junior resident who worked with us selected in general surgery in our own institute. This is the neuro navigation equipment which got installed yesterday. I think it will be available from next week onwards. We are ready to use it, sir. We already done 4 cases with neuro navigation. This will improve the pedicle screw placements. So the screw will go where we want, not we can't. It will not allow us to. And brain tumors and accurate localization of brain tumors, accurate excision of brain tumors, and shunt placements. All these things it will help us. So future plans, with the help of the neurology department, we are going to start an epilepsy program. Major work for epilepsy, the work is by the neurologist. They have to select the case, evaluate the case. Surgical work is only a part of it. This year, plan is to apply for a PRNB program in neurosurgery. We will forward, as you said, sir, we will forward the requirement for the neuroendoscopy equipment. And also we need a high-end neuromicroscope. The present microscope, the vision is dull. Of course, we can manage for the time being. These 2 endoscopes, neuroendoscopy, high-end neuromicroscope, these are our further requirements, sir. Thank you, sir.
Good afternoon to everyone. From Department of Gastroenterology, myself, Dr. Pinnamaneni. Presenting, this is the census of our outpatient. This is a slide showing 23 and 24 and 25 is 4,000 and in 25 the census are 6,239 OP census. Procedures, diagnostic and therapeutic procedures we are doing regularly in the Department of Gastroenterology. Diagnostic procedures, endoscopies, the census in 23, 24 and 25 we are doing. Colonoscopies. Therapeutic procedures in Department of Gastroenterology at Institute of Medical Sciences. We are doing almost every therapeutic procedures available, which are currently doing in the almost any other premier institutes, like endoscopic retrograde cholangiopancreatic ERCPs, and also endoscopic varicose ligation of varicose banding, and also application of hemoclips for the ulcers bleeds, and the organ plasma coagulation of the bleeding ulcers, and also we are doing foreign body removals. All the therapeutic procedures we are regularly doing in the Department of Gastroenterology. ERCP procedures is started for the first 3 to 4 years in here. In 23 the number of procedures was 30, in 24 is 40, in the last year number was increased to 52. Almost we are regularly doing the 5 to 6 cases averagely ERCP procedures. Almost if you take any institute, we are having at least 2 to 3 DM seats. They are also regularly almost doing this type of regular work only. This is a study we have done at SIMS Pinnamaneni Institute of Medical Sciences. There is a correlating the severity of the pancreatitis with the relation to the serum procal levels. Thank you.
I am Dr. Pinnamaneni from Department of Nephrology. I will be presenting our review for the last year. So this is the outline which we will be going in. The changes is for for those of you who don't know, our department OPD has shifted from second floor to first floor. So now we are in the urology block. So I think it's still not known to everyone, just for information. Statistics wise, these are OP and IP. Before going to the statistics, just a small footnote is that our department was closed for almost 20% of the months last year. So almost 1/4 of the time, department was closed either because of renovation or my absence or some logistic issues. So the numbers are not exactly as high as we wanted to be, but still there is significant improvement. So we are doing almost 9,000 dialysis, we did almost 9,000 sessions of dialysis last year. IP and OP both are increased. And the monthly dialysis sessions, which Initially we had started with 250 this pre-COVID levels, then went up slowly. Now we are touching about 750 sessions per month. The same thing, almost 32% increase in the dialysis sessions, and the OP and IP is significant improvement is there. This the same dialysis sessions going up. So maybe next year we'll be touching 900 sessions per month with the innovated device, innovated unit. These are the other procedures which we do using our dialysis machines. Plasmapheresis, Siemens option is for predominantly poisonings, then SET is for hypertension patients, and SCUF is for cardiac failures, and acute peritoneal dialysis. The other interventions which we do, the peritoneal dialysis catheter has come down because initially it was reimbursed by the government, now the government reimbursement has gone. So we do not have much patience for that, that's why PD procedures come down, other things are going down. And again, as I told, numbers are slightly low because 1/4 of the time the department is closed. The same thing in the procedures. Transplant, again, we had a fewer number of transplants last year because of OT innovations and as well as our department closure. So a total of 3 transplants last year, 2 live and 1 cadaver. If we take the overall statistics, we have 85% graft survival and 80% patient survival since initiation of the program. And the deaths were mostly because of patient-related factors. One was poor compliance, did not take the medications properly, and the other one was CK-related complications. Coming to the academic performance, these are medical postgraduates who presented in the World Congress of Nephrology in February 2025. And I was the faculty for the World Congress of Nephrology, where we conducted a dialysis workshop and also as a part of a social media team. Then for Asian Pacific Society of Hypertension, I went as an ambassador on behalf of International Society of Hypertension. So I was representing the International Society on behalf of International Society of the Asian Pacific Society. These are the ISN conference where we are doing the workshops and the AIMS nephrology conferences, then Urban Transplant Conference in Ahmedabad and Goa, then our Southern chapter. This is in Shanti Medical College. So these are different talks we had given, presentations we had given. Coming to research, last year we had, these are the 5 abstract presentations and followed by 5 original papers. So we had about 10 publications last year. And the 5 have been submitted, they're still under review. So achievements wise, if we go for clinical, academic and research, clinical achievements, when we started following World Hepatitis Day and World Hypertension Day, it was celebrated on March 27th. And on World Hypertension Day, this was done in Veterinary College and NCC unit, where we had done free screening for everyone, and we had donated B apparatus to the NCC unit and to the Veterinary College. Coming to academic, my previous goal was we wanted to conduct a CME in our institute. Instead of conducting CME, we had one assistant professor from nephrology who came as a visiting fellow for learning through skills and advances and others. So he is Mr. Dr. Amrut, who came for visiting. He wanted to learn about perm cath. So after completing his training, he was here with 2 weeks in Pinnamaneni with us. He went back and he independently performed his first catheter position in Nepal. After this, again as I see, he called me for. I had gone to Nepal to do a workshop there. This is there in Nepal. This is in Pokhara Institute of Medical Sciences, where we did a hands-on workshop and we were teaching PD catheter insertions and PD catheter repositionings. And this was another CME session which I conducted in Nepal. Research, we started a new thing, new society, Indian Society of Polycystic Kidney Disease. Currently I am the treasurer of that society. And we have formed the G20 nephrology group with 20 nephrologists across India, who focusing on research and collaboration. So far from under G20, 2 articles have been published, 5 articles are submitted under review, and we have 4 more studies which are ongoing now. We are planning that at least next year we will be having 10 studies for next year, 2026. So that's on the work aspect. So, and it's not just work, we also have some fun. This is main initiative by Prasad sir, post for today. This is an inter-department meet for our specialties where we meet every month. This is these are medical postgraduates who passed out last year, just recently conducted medicine PGs, and these are medicine assistant. Then there is a SGPGI HOD, actually SGPGI director. We were with him in Goa. And we went to Nepal. This was in Nepal. Apart from study, we did have some fun. And with me, one more Dr. Harshavardhan. He is an intern who just passed out in this March. He passed the internship from, so he came with me. He's working with me as a research assistant. He came with me for Nepal for presentations. And this was in our Indian Society of Nephrology, where we won the Interzonal Cricket Championship. The goals for next, these were the goals which I presented last year. Out of them, transplant we could not achieved so far. In transplant department also we wanted to form a multi-organ transplant department that has not been formed. CMA workshop, I planned a workshop, but each workshop I invited a fellow to learn with us. And these are the thing which international collaborations we have done, clinical trials that we initiated, and we also started doing drug trials in India. So these all goals have been achieved. For the next year, hopefully we'll be able to start a multi-organ transplant program. And district, we'll be moving on to EMR. Hopefully we can move on to EMR. Academic wise, hopefully 15 publications. And we are doing clinical trials as a site. We want to form a clinical trials network which is recognized internationally. And we are also working on developing new point of care devices for investigations. Thank you.
2 minutes. I am presenting the Department of Neurology 2025 statistics and data for academics. This is our OPD statistics. Total around 19,000 change patients. This is our OP census when compared to 2024. There is an increase in the patients in OP, almost 20%. Coming to IP is also there is increase in IP census. So OP census has increased nearly around 20% and IP increased around 5% of the patients. These are our procedures, EEG and NCS procedures. We did in the last year. We need improvement in these statistics. This is our research work. Total we have around 9 publications last year, and these are accepted case reports yet to be published. These are an ongoing research work in our department right now. And we presented around 16 interesting cases in the last year in our academic. So, thank you.
This is the monthly census of OP, IP and OT. Total number of 13,010 cases of OP cases and 1,707 of procedures, which includes both minor and major. And these are total 11 cases of major interesting head and neck surgeries we performed in 2025. And coming to academics, 110 seminars and 42 journal clubs and 100 case presentations, 29 grand rounds and 1 CPC and 3 interesting cases were performed, and total number of 8 publications were published, and a total of 29 PG papers and 5 consultant papers were presented in State and South Zone Conference. Performed in the State and South Zone Conference, out of which 4 PGs got gold medals and 2 consultants got gold medals. And as a part of Golden Jubilee celebrations, we participated in Arogya Avagahan Pradarsana and also conducted Neck Explore, which is a hands-on cadaveric head and neck workshop, which is first time ever done in the state of AP. This is the glimpses of the Neck Explore, and these are some festivals, eves which we have celebrated by and in our department. Thank you.
Of Pediatrics. We are privileged to have with us Dr. Diti Vepakoma ma'am, Professor and HOD, Department of Pediatric Surgery at All India Institute of Medical Sciences, Mangalgiri. She is also the currently Student Welfare Dean. She did her MBBS, MS, MCH from Kasturba Medical College, Karnataka. She worked as faculty in Department of Pediatric Surgery in Bangalore Medical College and Research Institute, and also worked in various other hospitals. She joined AIIMS Mangalgiri in 2021 and working till date. She has over 24 years of experience as pediatric surgeon and also played a key role in establishing Department of Pediatric Surgery and MCH training program at AIIMS Mangalgiri. She was trained in robotic assisted minimal invasive surgery at Children's Hospital of Philadelphia and also certified for advanced laparoscopic surgery. Her clinical expertise spans the full spectrum of pediatric surgery with special interest in minimal access surgery, complex spina bifida and thoracic surgery. She also has an active academic and research profile with multiple national and international publications. We are honored to have her with us today and looking forward for an interesting discussion, ma'am. Now my co-PG Dr. Praveen will start the session.
Myself, Dr. Praveen. Good afternoon, everyone. Myself, Dr. Praveen, pediatric resident. Now coming to the case report. Name, baby of X, sex, baby girl, date of birth 19/6/2025. Time of birth 7:32 a.m. Of birth weight 2.7 kg, which is appropriate for its gestation age. Mother details. Mother was late registered case. First visit to Dr. P. SIMS RF at 30 weeks of gestation. Maternal age 27 years, marital life 10 years, non-consanguinity. Period of gestation 36 weeks 3 days. Comorbidities PCOS, no hypothyroidism or maternal diabetes. Obstetric score priming gravida. Antenatal scans. NT scan not done, anomaly scan done outside at 24 weeks, which showed intra-abdominal mass measuring around 4.4 into 5.8 centimeters, noted in the fetal abdomen, and showed polyhydramnios. Fetal Doppler study was done and was normal. Baby details. At 36 weeks, 3 days, late preterm, baby girl born through emergency LSCS in view of leaking per vagina on 19/6/2025 at 7:32 a.m. with birth weight 2.7 kg. Baby cried immediately after birth and Apgar score was at 1 minute 7, 5 minutes 9 and at 10 minutes 10. Day 0. Baby was shifted to NICU in view of abdominal distension at birth for observation. Not past meconium after delivery. Post delivery NG aspirate revealed 25 ml BS aspirate. UVC secured. General examination. Baby is active alert. Baby is in flexed posture, moving all 4 limbs. All peripheral pulses were felt. All peripheries are warm and pink. No icterus. Abdominal distension present. Vitals. Heart rate 142 per minute. Respiratory rate 51 per minute. SpO2 98% on room air. Temperature 36.5 degrees centigrade. PP 64/38. MAP is 47. CRT less than 3 seconds. GRBS 90 mg per dl, which were normal. Systemic examination. GIT inspection. Upper GIT, no cleft lip or cleft palate. Lower GIT, abdominal distension present. Visible bowel loops in left flank. Umbilicus is in midline and no discharge. No abdominal wall erythema. No visible intestinal peristalsis. Hernial orifice free and external genitalia normal. On palpations, abdomen is soft and non-tender. No guarding or rigidity. Diffuse mass felt over right iliac fossa, right lumbar and umbilical quadrants. Soft in consistency. Size approximately 7 into 5 centimeters. Ill-defined borders. Mass does not move with respiration, non-pulsatile, non-compressible, no hepatosplenomegaly. Abdominal gap with 34 centimeters. On auscultation, bowel sounds were heard. Nasogastric tube aspirate revealed 60 ml of bilious aspirate. Anus was patent and thick, white, small amount of viscid mucus plaque expelled after probing with infant tube. Respiratory system, bilateral air entry equal, normal vesicular breath sounds heard, no retractions. Cardiovascular system, S1, S2 heard, no murmurs. CNS, anterior fontanelle flat and open, tritone activity good, routings again present and morose complete. In view of abdominal mass, pediatric surgery consultation was taken and appropriate investigations were sent.
You mentioned about the urination.
On day 1, urine output was 1.5 ml per kg per hour.
So this child was actually antenatally, there was a suspicion of a cyst or a mass already.
Yes, ma'am.
We are already aware that there is some problem.
Yes, ma'am.
So when you said investigations were done, you can go to just that one slide which you just said appropriate investigations. What would you consider as the appropriate or the first basic investigation which you would want to do?
Blood reports, ma'am. Blood reports and X-ray abdomen, erect X-ray abdomen.
So maybe we'll go through the entire sequence and then.
At this point, before you go into the discussion of the investigations, I like to ask the discussant what the probable things from antenatal to the postnatal diagnosis as a discussant.
So generally, when you mentioned that we have good afternoon. I think he mentioned the fact that there was already a suspicion that there was a mass or a cyst which was antenatally picked up. And in view of that, I think what comes to our mind first is to look at what is the gender of the child. because if you are looking at cysts, intra-abdominal cysts, and we are considering a female child, ovarian cysts are very common. So that is something that we need to keep in mind. Again, that is innocuous. Now the idea or the reason to have a suspicion is also because it helps us in counseling. Not all problems are actually morbid. Many of them don't require emergency intervention. So counseling would be appropriate for those of you who are here from the Department of Obstetrics. I think your quote here, we care, he cures, is very apt because parents always come with that anxiety about termination or not, what to do, why this happened. So I think that's where we need to allay. So I would look at considering in the antenatal that. If not, mesenteric cysts are again very common and they are also benign with no emergency issues usually. Apart from that, when we talk about a mass, what we would want to know is, keep in mind that there could be certain tumors which can be present even prenatally. Though it is not common, we are aware of sacrococcygeal teratomas which are external most of the time, so it's visible even on scans as an external mass. But even intra-abdominal, we would always keep in mind that there is a possibility of a tumor, though it is less in order of priority. So those are the things that we would consider at this stage before we evaluate postnatally. Looking at his examination, I think you mentioned that the baby looked quite stable, right? Hemodynamic stability again tells us that we have time to evaluate. But the baby already has distension at birth. Now if we try to look at the clinical examination, it may or may not match what was given in the antenatal because that picture was not very clear, the antenatal ultrasound. With distension, we want to know two important things. In the examination, whether the baby has an anal opening. That is one thing. I will put up slides a little later and show you pictures, which is very often missed. And so we could be dealing with anorectal malformations, distension that has inadvertently not been noticed, especially if the delivery happens in a remote area where there is no pediatrician available, right? If not, in a newborn, to actually feel a mass is not very easy. But any upper abdominal mass, having adrenal gland, a hemorrhage or a mass in that is also noted, and we have seen recently we've even done a tumor that was there in a newborn. So with that we will, that is the basic clinical things would be to look at bowel pathology or to look at some kind of a benign cyst. And bowel would invariably be some kind of an intestinal obstruction. The level is usually we are looking at large intestine or distal small bowel because the baby has gross distension, right? So simple investigations will actually help us pinpoint what the problem is.
I would like to add a...
The ultrasound already mentioned about cysts. So your provisional diagnosis will probably be relying more on this.
More common lesions.
Yes, that is what I think you've covered most of it. When we talk about omental and mesenteric, what we are looking at are some versions of lymphatic cysts. Even retroperitoneum, you are talking about a lymphatic. Yes. So that entire group will be lymphatic. Ovarian, as we said, in female child, that should be another thing that we would think of. Duplications being very large like this is not common. So that is again going to be something which is low down in your priority. Ovarian cyst is something that is what we would mainly consider. If you do not have any other, as I said, rule out anorectal malformations, right? Because in a female child, another important thing that you need to examine is the perineum. I will again just put up slides later to show, because if you have a cloacal malformation, many times they will have what is called as a hydrometrocolpus, right? That means the entire vagina is filled up with urine because the external passage is very small, single opening in the perineum. So they present as very huge lower abdominal cystic masses.
Treatment at NICU, IV fluids 10% extra, 60 ml per kg per day, day appropriate. Injection piperacillin plus tazobactam, 100 mg per kg per day, IV 12th hourly. Injection metronidazole, loading, 15 mg per kg per dose IV start, followed by 7.5 mg per kg per dose IV 8th hourly. Injection amikacin 15 mg per kg per dose IV 30th hourly. Injection ranitidine 1 mg per kg per day IV 12th hourly. Replacement of rice tube aspirates with intravenous fluids, ringer lactate. Investigations were done. HB 15.2, total counts 11,500, platelets 2,77,000, peripheral smear was normal, CRP 1.3, GRBS 90 mg per DL, LFT was done and was normal. Serum electrolytes were normal and RFT, blood urea 20, serum creatinine 0.6, and coagulation profile was normal and vitals were negative.
These are frontal projection radiographs, abdomen, supine and erect. Here we can see some abnormally dilated small bowel loops centered in the left upper quadrant. Also on the erect film we can see there are abnormal multiple air fluid levels in these dilated small bowel loops, which indicates intestinal obstruction. Also there is this homogeneous opacification of the lower abdomen. In view of the given history and natal report, this could represent some mass lesion or a cyst that is displacing these dilated bowel loops towards the left upper quadrant.
If I can just add a few comments here. One, I'd like to know from maybe microbiology or in general department here, you all have an antibiotic policy in the institute, I'm assuming. So just a question on why we would look at having piptas as the first line of antibiotics. I mean, this is just a query because if the patient is referred from a periphery and we do not know neonatal sepsis is of concern, then we would like to start higher antibiotics. But if it is an inborn, why would we want to? So this is just a query because we are in this area of antimicrobial resistance and we want to be a bit cautious with regard to what we choose.
Definitely, ma'am. Actually, this was referred from a periphery and then it had come to our obstetric team and then it got delivered here. So we were not having much idea about the antenatal part from that remote area because obviously the documents. Here we are very careful with our antibiotic policy in the NICU. We follow guidelines which are given mainly by standard institute like AIMS, and we have also our own institute guidelines which are in this with the AIMS protocols. Our initial antibiotic is ampicillin and amikacin, madam. Second would be piptas and this, because here we had to go for a higher antibiotic because there was an abdominal mass and it was referred from a periphery and it's a neonate with the possibilities pre-op also we have to make sure that all the sepsis and part is taken, early onset sepsis is taken. So that's why we went up high. Thank you.
Will it be possible that it is an outside case referred with sepsis related enterocolitis, necrotizing?
Sir, if it is a necrotizing enterocolitis, the neonate would not be stable. Intrapartum itself, there would be a lot of troubles. Apgar would not be normal. We would have a child who had to be resuscitated.
Near normal Apgar excludes
yes,
near
and
normal,
the clinical examination at birth.
Most unlikely.
Now this neonate was brought to the NICU because of the mass. Otherwise, he was hemodynamically stable for the evaluation of the mass. And otherwise, he was hemodynamically stable to be staying mother's side. Or she was staying mother's side. So, if we look at the perfusion and if we look at all the vitals, they were normal. So, that is why blood pressures, perfusion, the respiratory rate, the heart rate, the breathing pattern. And we didn't give any oxygen pre-op. So, all this. So, the change. And the only thing we used piptas was a remote, from a remote location, it was brought for delivery here.
And USG abdomen and pelvis was done. A well-defined cystic lesion with internal echoes and dependent debris measuring 7.1 into 3.8 centimeters noted beneath the abdominal wall, predominantly on the right side of abdomen. Few bowel loops noted. Posterolateral to the cystic lesion appears prominent. No free fluid noted in the abdomen and pelvis at the time of scan. Impression. A well-defined cystic lesion seen beneath the abdominal wall, predominantly on right side of the abdomen. Few bowel loops noted posterolateral to cystic lesion appear prominent.
Kidneys? Comments?
Kidneys were normal, sir.
mention it?
Yes.
Because when the kidneys are normal, we excluded a good number of rare conditions. Because one kidney may go for a cystic nephroblastoma.
They are also considered in the definition as cystic nephroblastoma, then giant hydronephrosis, or any megaureters. They can present as a mass. Megaureters, duplex stents with a megaureter, they can present as a mesocolic mass. So they can have a cystic presentation. Yeah, that's it. Yeah.
Positivity of the presence will exclude so many negative lesions.
Discussion.
These are radiographs of contrast enema. So this is a plain radiograph taken before giving the contrast. The feature same as described earlier. So we can see these multiple abnormal dilated bowel loops in the left upper quadrant, and there is no rectal gas shadow. So implies some small bowel obstruction at a small bowel level. Possibly jejunal. So here we can see there is administration of contrast into the rectum, and there is contrast opacification of the rectum as well as descending colon. It is diffusely decreased in caliber. So this might possibly represent immature colon or microcolon.
There are some filling defects also in the rectal.
The filling defects are seen on some fillings, not seen in the lateral radiograph. However, they may represent meconium plugs or some specific.
During the procedure, actually the baby was not holding the contrast. She was expelling it out, and during the procedure some meconium, white meconium had come out. So there were no normal colored stools or normal brownish meconium coming out. It was only a white meconium, thick viscid meconium. And she was expelling this thing, water-soluble contrast which was given. So we had only a limited study, and which showed a micro colon, unused colon with a few pellets of meconium. So we could not image the entire colon or the distal ileum in this procedure.
Yes, so I think the fact that there is some kind of a space occupying lesion pushing the bowel loops is quite obvious on all the x-rays that we have seen. If you have those air fluid levels, we are almost certain that there is some obstruction, like how she just interpreted it. An indirect way to confirm that there could be an atresia or a small bowel obstruction would be to do a lower GI contrast, because we do not want to do anything in the upper GI. It's going to risk aspiration, or if there is an obstruction, you're going to worsen it. So the fact that there is a microcolon almost inevitably is diagnostic that there is an atresia or a small bowel obstruction, and this is clearly a functional microcolon. Because of disuse, because of no meconium coming, it's very small in size.
It cannot be an organic component unless otherwise proved.
So organic, we are looking at HER2, which it is not.
Yeah.
We can quite clearly rule that out. If there was anything like a rectal atresia, that also would be quite clear in this. Like sir has mentioned, when there are white pellets, it's not functioning. It's not functioning, and it is not functioning altered. Only the caliber gets reduced. So that is why I am saying functional. Sir also asked me that question. So it is functional because only the diameter has reduced. But the normal long, if you see sigmoid, it has a long mesentery, it has curves, right? The transverse colon kind of loops down. All that anatomy will remain the same if you are able to trace the contrast. But in a total colonic aganglionosis, the bowel is foreshortened. So classically MCQs, they will say question mark sign. So you've lost all the hostrations, you've lost the normal length. So the entire transverse colon is like this, and then the descending colon and sigmoid is another straight line. So it's almost like as if you have a question mark there. So shortening, that would tell you that this could be a TCA. So here it is unlikely to be that.
So another cause for neonatal small distal bowel obstruction, small left colon, that is the baby is born to diabetic mothers, where the splenic flexures are all rounded and Madam said the question mark figures and all these things.
Though we still haven't addressed the problem that there is a cyst also. Right? We've done this. We know there's a microcolon, but we still haven't, like I said, that almost confirms the fact that there is an atresia probably, but we still have one mass lesion sitting there. So whether that itself is something that we need to think of as saying, could there be an antenatal perforation, is something that we need to keep in mind. Because there are internal echoes. So what is all that? Is that some meconium and other content that has come out and then formed a cyst?
Non-diabetic. No, sir. Cardiology referral was done. 2D echo report showed ostium secundum AST 3 mm with left to right shunt, patent ductus arteriosus of 0.8 mm, mild tricuspid regurgitation. Yes, sir.
Time. Age is only 2 days.
Yes, sir. Day 1.
As soon as the child takes birth, there is a physiological closure. That means spasm of the duct and the shunt stops. But the anatomical closure, like fibrosis, everything takes 2 to 4 weeks like that. We are not interested in that. Mainly, as soon as the child takes the breath, first breath, the duct goes into spasm and no more shunt occurs, which was occurring in the fetal circulation. PJ is no question at all. There is a small shunt, may remain in a few patients, so physiologically closure occurs, but some 0.8 millimeter means less than 1 millimeter like that. So probably it is little, and I think it is not. And PFO is 3 millimeter is there. So some little shunt may be there initially also. It's a newborn. So the closure will occur normally, full closure of the PFO occurs by 3 months. So then no more shunt should occur. Our junior young doctors have written it. And the secondum means, see, if it is at the fossa valis region, that is the ostium secundum. So it's at the fossa.
On day 1, baby is active, alert, cry tone activity good. On examination, icterus present, no cyanosis, respiratory distress or interactions. Not past meconium met, passed small quantity of white colored mucoid plex.
Actually, they should have written patent PFO rather than secondum AST. That's the wrong terminology.
Vitals, heart rate 147 per minute, respiratory rate 57 per minute, SpO2 99% on room air, temperature 36.5, CRT 4 seconds, BP 68 by 40 mm of Hg, GRBS 81 mg per dl, gastric aspirate, high volume greenish brown aspirates. Treatment, in view of prolonged CRT infusion, dobutamine was started at 8 mics per kg per minute. Capillary refilling time is 4 seconds. Normally is less than 3 seconds. VBG at that time pH 7.34, PO2 35.4, PCO2 36.2, bicarbonate 19.2, glucose 108 mg per dl, lactate 1.7, base excess minus 5.4 millimole per liter. General examination. Abdominal distension present, no visible bowel loop seen, soft, no guarding or rigidity, no abdominal edema or discoloration. Soft lump felt in right lumbar, right iliac fossa and umbilical region. Abdominal girth is 35 centimeters, bowel sounds present. Serum electrolytes were done and was normal.
These are axial and sagittal plain CT images of abdomen. Here we can see a large homogeneous, well-defined cystic kind of a lesion. It has no abnormal calcifications or no extraperitoneal free air. Here we can see there are some dilated bowel loops which are displaced by the soft tissue lesion. These are contrast enhanced CT images of abdomen, axial, coronal and sagittal planes. Here we can see the well-defined large cystic lesion in lower abdomen and pelvis. on right side, or the extending on the side, placing the dilated small bowel loops into the left upper quadrant. Left kidney, there are some calcifications seen along the wall. So in view of the given history, prior radiological investigation and examination findings, possibility would be a meconium pseudocyst. Other possibilities would be a ovarian or some mesenteric cysts.
I think calcifications clinches your diagnosis with compared with putting all the other findings together. I have only one query or a comment. Again, I would like the pediatricians here to also talk. I'm a little averse to CT scans being done in children, infants and children in general. So maybe sir also can just give inputs regarding, we know there is high bilious aspirates and there is air fluid levels and there is also a cyst. So clearly there was something happening which, it is not a benign ovarian cyst which we can wait upon. So a laparotomy almost becomes inevitable here with just the ultrasound, the radiology that we have done so far. So would the CT scan actually contribute more to getting us a diagnosis? And the general opinion of the house also with regard to CT scans in children because of the radiation exposure.
We usually don't advocate any invasive procedures in the newborns or children, madam. Here also, we were our first line because we were discussing with the pediatric surgeon and all, and we were as a team we were discussing as to how to progress further. We started with we did all the hematological investigations and we found that all the electrolytes, everything was normal because of the distension. Then we went for X-rays, then we went for contrast enema and all. Little more towards the diagnosis it would be pointing towards. That is
in between your MRI which is available and CT, you like to prefer a CT in this case?
MRI is definitely a better option in neonates, but the
diagnostic possibilities you prefer.
But sedating the neonate for such a long time and subjecting to hypothermia, it would be a very drastic step. So CT would be better. We have discussed with the pediatric
Not with reference to the outcomes of diagnosis.
It takes at least a half an hour, but if supposing it is contributing...
you think of a calcifications, an MRI is a little inferior to...
Sir, if supposing it is a refractory neonatal seizures and all, where it will contribute to the neonate, definitely we'll go for the MRI. Subjecting the neonate is a preterm, subjecting that preterm to about half an hour of cold stress. So it is very difficult. CT also, after discussing with the surgeon and after surgeon has given a green go, we have to proceed. Yes, sir.
Yeah. Therefore, as far as the cystic component is concerned, preferably a calcification is better admissible with the CT rather than MRI.
Actually, in addition to the cyst origin, where it's arising from, if you can get more information than a plain ultrasound percent. So we had a ovarian cyst, we had initial diagnosis of
but as far as
bowel.
this case is concerned, twice ultrasound was done, antenatal ultrasound and postnatal. But they didn't pick up any amount of calcifications at this point of time.
No, it was not picked up. It was not picked up on plain X-ray abdomen, any calcification in the cyst wall. So, for delineating that any calcification in the teratomas, retroperineal cystic teratomas in the wall, so any calcification, CT is better than plain X-ray may show, with tooth or...
If it is a CT, you like to make a comments of the few or 3 or 4 cases of calcifications of this type of cystic, which can be differentiated by your CT as a radiologist. Pattern of calcifications.
So the classical description may be a flocculent or a amorphous calcification, curvilinear in the cyst wall.
The cyst can have a curvilinear type of calcifications in the periphery, or if the cyst ruptures, you can have nodular or floccular type of calcification within the peritoneal cavity, depending upon the type of the meconium peritoneus.
Read at the point of time. What are your priorities of a cystic? Three operations.
must contribute to the diagnosis. I think that's the general, the idea of being an academic practice. We need to not just list out and say, I have all these and I did it, but is it going to add to the information and then change my line of treatment? And then that I mentioned earlier, sir, because we are lately seeing so many who pain abdomen, appendix not seen, do CT for it, and why appendicitis doesn't warrant having a CT scan, right? There are so many ways we can come to that conclusion. So basically, it is more because it's a newborn and it's a child and there is so much radiation, and as ma'am mentioned, hypothermia. There are a lot of other comorbidities that can happen when you expose these babies to radiation.
Therefore, there are no further investigations, there is only intervention. Before the investigations, we have already mentioned the final diagnosis with reference to that is a meconium cyst, vice versa, and ovarian abnormality. Still, as a second possibility, we are not going to waste time on investigations because she had a bowel abnormality and displacement. She needs to be interfered as early as possible. You agree to it or add to it?
Actually, the pre-operative investigations and after adequate preparation of the patient, we took up surgery on the third day. Third day, exploratory laparotomy was done. Exploratory laparotomy, right supraumbilical transmuscular cutting incision, and the findings, operative findings.
Now, at this point, we must congratulate our discussant for bringing out that it is most likely to be a meconium cyst, excluding the other two, including our ovarian, least possibility, and the mesenteric component and other lymphatic ones, and directly proceeding to surgery. Now, you make your surgical approach. Any anesthetist? Wonderful. Before the diagnosis of the meconium cyst at this point of time in 2 days of old baby, what is your purview with reference to the anesthetic assessment and involvement?
We look for all obstetric history, babies. Pre-anesthetic check, the vitals and history of birth history, any asphyxia signs of that we have to check up, and as abstract, we have to be prepared for general anesthesia, and prior to that we have to see if we are able to pass the nasogastric tube, and we have to empty the contents. Rest we plan for general anesthesia.
Procedure under general anesthesia and elective mechanical ventilation, exploratory laparotomy, ileolysis, excision of cyst, ileal resection, and endo-oblique ileo-ileal anastomosis, appendicectomy, and peritoneal lavage done. 50 ml intra-O positive blood transfused. Operative findings: giant meconium pseudocyst occupying right hypochondrium, right lumbar, right iliac fossa, umbilical, hypogastric regions, filled with greenish yellow turbid fluid. 100 ml thick walled cyst adherent to parietal wall, inferior surface of the right lobe of liver, gallbladder, urinary bladder, and bowel loops. No ascites, liver, gallbladder, stomach, and duodenum normal. Uterus, both fallopian tubes, ovaries normal. Microcolon present. Entire large bowel collapsed. No evidence of colonic atresia.
The first photograph shows the abdominal wall open and the cyst projecting on the surface, and the syringe is entering the cyst cavity, and the fluid contents are being aspirated. In the second photograph, which is showing the nature of the fluid which has been aspirated, around 100 ml were aspirated of this character, and this is suction aspiration of the cyst after it is opened, and subsequent pictures. And this is showing the opening in the cyst cavity. This is the parietal wall on either side, and this is cyst cavity, pseudocyst cavity, and the cavity inside. Here, this is showing the dilated proximal ileum, which is ending blindly. And this part is after the evacuation of the contents of the cyst, this is the cyst wall. And the distal ileum was opening into the cyst. And this is the completely excised cyst wall. And here is the distal ileum was opening into the cyst cavity. And this is the resected segment, which was filled with distal ileal segment filled with pellets, and the proximal dilated ileum was blind ending actually. Next one. So again, this is the showing the opening of the distal ileum opening into the cyst cavity, and here the anastomosis, end to oblique anastomosis was performed after excising the dilated proximal bulbous tip of the ileum and the distal narrow segment which was there was excised, and end to oblique anastomosis. Because of the luminal disparity, end to oblique anastomosis were done in 2 layers, and before doing completing the anastomosis, the distal ileum loop was flushed with normal saline to remove any pellets which were present near the IC junction, as well as we milked it into the colon. And as we did the irrigation of the distal ileum, we found that the saline was emptying into the rectum and through the anus. So it assured that the distal colon was patent. It confirmed our previous findings, anatomical findings. This is the final completed anastomosis on both the sides. Okay, photos. So actually the findings were, there was a volvulus of the mid-ileum segment. As soon as we drained the cyst cavity, all these contents, there was dense adhesions present between the parietal peritoneum, liver inferior surface, gallbladder, adjacent bowel loops, urinary bladder also. So the cyst was walled off from other organs on all the sides. So after draining the contents, we found that the volvulus of the bowel loop, the mid-ileal segment. And then, after freeing all the adhesions, the proximal ileum was blindly ending, and the distal ileum was opening into the cyst wall. So distal, after resecting a short segment of the distal ileum, we did distal irrigation of the distal ileal loop, and proximal and distal ileal anastomosis was done, and appendicectomy was done. Just to see the ganglion cells are present or not, because we initially there's a microcolon to confirm the histopathologically, as well as once we are considering that is a thick viscid meconium is there, whether any meconium ileus, the histologically they can show some features of goblet cell hyperplasia in cystic fibrosis. So for that, there are 2 reasons I did that appendicectomy. Otherwise, it's not warranted to do appendicectomy. Yeah. Those 2 reasons were the indication for performing appendicectomy with peritoneal lavage, and then the post-op progress you can correct.
Specimens were sent for histopathological examination.
No, I think surgically, no comment, sir. Just that you said it is a pseudocyst, which sir has demonstrated. So it's not a true cyst, that word that we need to know. And it's a probably complicated meconium ileus, or in this case, the atresia or antenatal perforation, as we were discussing earlier, which has resulted in that entire collection forming a pseudocyst. I think the anatomy was beautifully demonstrated in those photographs.
So we have received a total of 3 specimens to the Department of Histopathology. The first one is the cyst along with the distal ileal segment, the proximal ileal segment, and an appendix. So this is a focused photomicrograph. So this is a focused photomicrograph of the cyst in a HND stain section in low power, showing fibrocollagenous cyst wall which is lacking the true epithelial lining, along with adjacent muscle and adjacent congested blood vessels and few inflammatory cell collections scattered. And this is the distal ileal segment which is attached along with the cyst, showing normal ileal mucosa with focal areas of hemorrhagic necrosis. So here we could also see areas of calcification in the ileum and also in the cyst. And here we could see a few bile pigment like debris and histiocytes scattered all around. So all these features are in favor of meconium pseudocyst. So this is the separately sent proximal ileal segment. Here we could see normal ileal mucosa and few inflammatory cell collections in the lamina propria. And so this is the normal looking proximal ileum with few inflammatory cell collections. So this is the separately sent appendix specimen showing all layers of the appendix and transmural acute inflammatory cell collections predominantly comprising of neutrophils, this suggesting acute appendicitis.
The purpose of the appendix is not being evaluated by your histology. You would have done some amount of cosmic acid and other things trying to know that it is not a aganglionic component.
Fluid was sent for culture and no bacterial growth was seen. Whole exome sequencing was done and was negative for cystic fibrosis. Final diagnosis: late preterm with neonatal intestinal obstruction due to complicated meconium ileus with giant meconium pseudocyst and ileal atresia. A synaptic congenital heart disease, PDA 0.8 mm, AST 3 mm. Status post exploratory laparotomy, adhesivolysis, existence of pseudocyst proximal to distal ileum, N2 oblique ilioileal anastomosis, appendicectomy and peritoneal lovis. Post-op day 0. Post-operatively, baby was shifted from the OT to NICU on elective mechanical ventilation and vitals were stable. Treatment: infusion dobutamine 8 mics per kg per minute continued, injection paracetamol 10 mg per kg per dose, IV 8th hourly added for pain management, IV bolus 10 ml per kg normal saline given in view of metabolic acidosis. Post-op blood transfusion 10 ml per kg done over 2 hours. pH 7.242, PO2 41.7, PCO2 44.4, bicarbonate 17.7, glucose 92.5 mg per dl, lactate 3.5 and base excess minus 8.4. Pre-bol.
You already ventilated.
There is a pain scale, sir, now. Yes. According to our Nelson textbook of pediatrics, there are pain scales now. Pain is a very big chapter now in pediatrics, where you have phases scale, you have PIP scale and Dan scales, which abroad now the nurses are given a chart to look at the neonate because he can't communicate. So, as far as American Academy of Pediatrics has come up with the pain scale. You have pain scales for neonates who are term babies. There is separate pain scales for preterm babies and children also. And there is a phases scale also. So, pain is a very big chapter now in pediatrics.
Also, I think the old concept that newborns don't have pain is not valid. You've done a major surgery, there's a laparotomy wound, to expect that this child will not have pain is wrong. So definitely pain management is warranted.
3 to 4 hours the neonate was in the OT. We have, as pediatricians, we have transported from the OT in a very euthermic environment. Then we have put the baby, then we have transfused the baby, we have given the support of inotropes, we have given a bolus, the baby through seizures, and now it is this. Then we have, so it was very difficult for the pediatric team to manage a preterm neonate, but we have put a lot of effort to salvage the neonate so as to give a healthy baby to the parents. So further slides. Here we have pictures. We have pictures.
8 hours post-operatively, baby developed 2 episodes of seizure-like episodes, cyclic movements of legs, left hand twisting, tachycardia, dilated pupils and sluggishly reactive to light. Vitals: heart rate 190 per minute, respiratory rate 54 per minute, SpO2 98% on mechanical ventilation, temperature 36.5, capillary refilling time less than 3 seconds, BP 60 by 45 mm of Hg, GRBS 70 mg per dl. Relevant investigations were sent and anti-epileptic medication was started. In investigations, serum electrolytes were normal, RFT was normal, but serum calcium was 7, which was low for a preterm, and CBP was normal, CRP was 2. Treatment: injection midazolam 0.1 mg per kg per dose IV start was given to abort seizures. Loading dose of injection levetiracetam 40 mg per kg per dose IV start given. In view of third episode of seizure, loading dose of injection phenobarbital 20 mg per kg per dose IV start was given. In view of decreased serum calcium, 10% injection calcium gluconate correction was given. Day 3 post-op day 1. Baby is on mechanical ventilator. On examination, baby is under sedation. Peripheries are warm and pink. Peripheral pulses felt. Not past meconium and bowel sounds present on auscultation. Abdominal 31 centimeters. Vitals were stable. Gastric aspirate 2 ml of clear. Abdominal 31 centimeters. Treatment continued same treatment. Investigations were done and were normal. Neurosonogram was done in view of seizures and was normal. Post-op day 0 babygram.
This is babygram AP view. There are no abnormal dilated bowel loops or air fluid levels, and there is no air under the domes of diaphragm, and there is endotracheal tube and feeding tube and umbilical venous catheter and drain tubes are seen in situ.
Day 4. Before extubation, investigations were sent. In which HP 15.6, total counts 11,900, platelets 2,14,000, PCV 47.7, TR total RBC counts 4.8, peripheral smear normal, CRP 1.3, and VBG was normal, and baby was extubated and weaned off to CPAP with settings FIO to 30%, PEEP 5 centimeters, flow 6 liters, and later to HFNC with settings FIO to 30%, flow 6 liters. In view of good respiratory drive, improved saturation and activity. On examination, baby is active alert, cryotone activity good. No episodes of seizures for 24 hours. Passed white colored mucoid stool. Bowel sounds present on auscultation. Laparotomy wound healthy and sutures present. Vitals were normal. Treatment: continued same treatment, and injection phenobarbital was stopped and infusion dopamine was tapered to 7 mg per kg per minute. Post-op day 2 babygram.
Post-extubation babygram AP view. There are no abnormal dilated bowel loops or air fluid levels, and there is no free air seen under the domes of diaphragm, and there are feeding tube, drain tube are seen in situ.
Day 5 post-op day 3. Baby was weaned off to room air in view of good activity and good respiratory drive. On examination, baby active alert, cryotone activity good. Passed stools 3 times per day, greenish brown in color. Bowel sounds heard on auscultation. Abdominal 31 centimeters. Laparotomy wound healthy, futures present. Vitals stable. Treatment same treatment continued, and infusion dopamine was tapered and stopped. Investigations were done and were normal. Post-op day 4. Baby is on room air. On examination, baby is active alert, cryotone activity good, passing stools regularly. Bowel sounds heard on auscultation. Vitals stable. On day 7, post-op day 5. Baby is active alert, cryotone activity good, vitals were stable. Laparotomy wound healthy, sutures present, drain tube removed. Treatment: expressed breast milk feeds initiated and fluids titrated accordingly. Non-nutritive sucking and KMC were started. Oral supplements were added. Post-op day 9. Baby was active alert, cryotone activity good. Laparotomy wound healthy, suture removal done, vitals were stable. Treatment: direct breast feeds every second hourly followed by burping for 20 minutes. Intravenous medication was stopped and syrup levetiracetam continued orally. Oral supplements added. Investigations were done and were normal. On post-op day 14 and day 16, baby was discharged on oral supplements with advice and follow-up. As the baby is active alert, cryotone activity was good. This is pictures of the baby on day 2 post-op day 1 and post-op day 10 and at 1 month of age. This is at 6 months of age. Baby had appropriate weight gain and attained all the milestones as per age.
Very heartening to see this picture, and I must commend the entire team, the neonatologist, surgeon as well as anesthetist. It's not easy to manage this. It is a challenge, and these kind of things is what keeps us going, I think, right at the end of the day, seeing a happy baby.
Surgery was one side, madam. Neonatology also, it was very difficult to manage because 3 hours, 4 hours the neonate was subjected to this, and so much of hemodynamic shifts were there, and all our residents and faculty of pediatrics was working very hard. And post-op it was very careful. We had to monitor because we had to take care of the sepsis part of it. We had to ventilate, then we had to go for gentle ventilation, then we had to extubate. While taking care of extubation also, again we had to go in a serial manner. And then after that feeds were started, and gradually this then KMC we started, so that the mother and the baby bonding would be there, and the milk secretion, because we can't go on top feeds now, so obviously so it was a very Herculean effort post-op also for the neonatal part to, and then we are seeing the beautiful outcomes, and parents are very happy, and we are following up, and the developmental milestones are normal. When they come for the pediatric surgery follow-up, we are following and vaccinating the baby, and they are under our care.
Wonderful.
Thank you, sir.
I have a couple of pictures. If we have time, we'll put it up. If not, we will, just to reinforce what we've just seen. And as they do that, I think just because this is an academic discussion, I wanted the pediatrics team, the current fluid management has shifted from Isolite P, knowing that it is actually hypotonic. Even for newborns who are termed, they prefer giving half DNS rather than Isolite P, which has been weaned off. We can look at the guidelines. That is what I have just read as per the new guidelines. Almost Isolite P is getting taken away from any hospital practice. So that is something that we can look at. The second thing, which is point for discussion for the surgeons and people who are here, is regarding drains. Because there are two schools of thought. Sir has chosen to put a drain. I come from the other school of thought who believes that drains have no roles. I think it's good to do a systematic review or some kind of a study, because there are enough people who have moved away from drains. And in the concept of ERAS now, which we are talking about trying to optimize and minimize the hospital stay, right? All of us, whether any person in the surgical side would know what ERAS is. Anybody wants to volunteer? No? Surgery people? Right? So that is something that we are looking at, because many times drains may get blocked, and it gives us a false assurance that things are okay because nothing is coming in the drain. So as I said, there are two schools of thought. I would not put anything as right and wrong. Medicine is all about individualized practice, what we see and how we would look at our past experiences and then manage accordingly. So sir can have some comments on that.
Actually, I belong to the old school of thought.
Yes,
Putting
sir.
a drain was mandatory in all intestinal anastomosis
I put it
in
the
our
other
time.
way around. As far as the adult component of surgery is concerned, has it been proved that the drains are not of much extra years, but not a newer concept?
Yeah, so that's why I said we need to look at.
Because when in the last century, drains used to be the component of every surgery. But in this century, adult surgery, drains are rarely kept except for a gastroenterology or something like that.
For instance, in pediatric surgery, whatever practice we are doing, in my previous institution, which was also very much a government organization, over the last decade, we have stopped bowel preparation completely, because we've proven that giving some peg leg and entire cleansing of the bowel before any kind of an intestinal anastomosis surgery is not reducing the wound infection rates or even any intra-op complication. So that is something we've done away with. Early feeding is again something we have incorporated. All these, I think going forth, maybe in your exams for surgery it will come up about ERAS and how you can be a little more aggressive, of course, with adequate scientific background to it. So I just had a few pictures which will add to what was just done, and we know that cases like this which have been detected antenatally can have various courses, and now we know there's an entire spectrum because of so much, including prenatal MRI which is being done. Most of the problems, as I said, can go into three groups. Either they're self-limiting, urgent intervention or early and even the prenatal intervention versus delayed. But we won't go into the details of that. I think it's outside the scope of today's talk. And I would again and again reinforce that don't leave us out. to the obstetricians and the pediatricians. I think unless we all work together, the outcome that you saw today is, I think, an exemplary example of teamwork. And again, I'd like to stress that in isolation, we can't do anything. But again, late referrals do cause a lot of harm. So having counseling done together, all of us conveying the same message to the parents will greatly enhance the way we actually provide patient care. So we know that neonatal surgery has a lot of risk, and ma'am has rightly pointed out the risks and the problems they had in managing this child, right? What I wanted to also show are a couple of examples here which actually tell us many times in neonatology we do not require any investigations beyond a basic plain X-ray abdomen with a clinical, and not passing meconium, having bilious aspirates are classical signs of something being wrong in the abdomen, and I think unless proven otherwise, you can go ahead and say this is a surgical case and it requires a laparotomy. Again, I wanted to just highlight this because I was telling you all about that vagina having a hydrometrocolpus with urine. So in a newborn, please look at perineum, especially in a female child. We often tend to miss because we just ask the grandmother, motion passed. You don't actually go and observe where it came from. So these are again many X-rays which almost prove that this has to be an intestinal obstruction and an atresia. Just to add to the picture that sir has shown, these are some of those which we have managed. You can see the discrepancy of the proximal and the distal bowel, and that is why I said the surgery that has done, it really requires another round of applause, because that discrepancy is usually 1:8 or 1:10. The proximal bowel is so dilated, and they invariably have prolonged ileus, something that was not done here, but we usually practice parenteral nutrition also, so that from day one we start TPN assuming that there's going to be a lot of ileus and that baby will go on to feeds only much later. So these are just more pictures of the same, including an important thing that we must remember, especially for the pediatricians here, regarding malrotation and the possibility of a midgut volvulus. So any newborn with high bilious aspirates, even if there is no abdominal distension, if the aspirates are green and the baby looks sick, it has to be a surgical cause. So don't delay, because you will have blackened bowel and this then becomes incompatible with life if there is a midgut volvulus. So this is again to just tell what happens when we have delayed referrals, right? So though this first child had a CDH, it was diagnosed antelatally, it was not intubated at birth, kept in the periphery, delayed referral, these things cause great harm. Similarly, a missed ARM, and in the last one, they started feeding and only diagnosed an esophageal atresia on day 7. These are all cases we have managed which end up with either severe morbidity or mortality. This is again meconium ileus, and sir was asking about that white pellet. So you can see that in meconium ileus the color is green. It's just that it's very viscid, very thick. And this is again a completion of the same image that sir could not demonstrate because that was so small, the contrast was coming out. Here you can see a similar picture. And this is again showing calcifications and a complicated meconium pseudocyst. So this is just a simple meconium ileus. And the last slide that I wanted to show was, this is a child we just operated about a month ago, laparoscopy. This child was 1 month old, antenatally detected to have a cyst. Same kind of a dilemma. It was a female child and we didn't know what it was, but the child was stable and this mass also was very mobile, and abdomen did not have any other signs to say we need to explore urgently. So we did an ultrasound, waited for a month because there was no need to subject that baby to an emergency surgery at newborn period. However, an ovarian cyst that is very large has a tendency to undergo torsion, so it needs exploration. Now, if you look at this, it was almost blue-black and it was floating. It was actually probably undergone a volvulus antenatally, and there was no fallopian tube, nothing. It was like just one round, nice cyst floating in the abdomen, in the lower abdomen, which is why we could say it was a mobile mass. So this was a simple laparoscopic excision. Because we were discussing about ovarian cysts, I thought this picture would just add to that. So these pictures were just to reinforce whatever we have discussed, and I'll stop with that. Thank you.
Thank you, ma'am. A simple, uncomplicated meconium illness which can resolve with a gastrograph in enema, or it may require an operative intervention if it is associated with ileal atresia, and then we can have either a decompressive enterostomy procedures or just irrigation techniques or a resection enhancement depending on what is required to be done at that time. Antenatally, the meconium ileus can present in 3 or 4 ways. One is perforation in the antenatal period, around in the second trimester, around 20-25 weeks. Then it can fibroadhesive type. There dense adhesions will be there. The perforation will seal off before delivery, and it will be resulting in neonatal intestinal obstruction. Second variety is the pseudocyst formation. Somewhere in the 7th month or 8th month, it can have a perforation, and then it forms a collection, chemical irritation following a pseudocyst formation. Third one, or it can just before the delivery, it can perforate. Meconium ileus can perforate, cause meconium ascites, which is usually sterile at that time. Or it can get infected postnatally and come as meconium peritonitis with septic shock. And patient will be hypertension, sick looking in that. And around cystic fibrosis is commonly associated in the Caucasians. Around 15 to 40% have meconium ileus, whereas in Oriental population, the incidence
of cystic fibrosis meconium and a primary meconium ileus, which you have a good prognosis.
Primary meconium ileus is without associated cystic fibrosis, which is more common in the Orientals. We don't find cystic fibrosis as commonly as in the West. But we have to evaluate because the treatment is now available for cystic fibrosis. So gene editing therapy is available. So we can antenatally, if we are, then we can counsel the parents for subsequent pregnancies also.
Gene presence is sufficient to make it a phenotypic expression of cystic fibrosis.
There are some diagnostic criteria for cystic fibrosis. Because only even if there is a gene evaluation by whole exome sequencing, there are about 6 variants of cystic fibrosis. So criteria, yes.
But phenotypically non-expressed.
Yes. So criteria is even if it is present, you have to go with the sweat, the clinical presentation, the family history, and the sweat chloride test also on 2 occasions. Neonates it's difficult, but we have to follow up and do because at least 100 grams of sweat is required.
Thank you for a wonderful, I congratulate the Department of Pediatrics and Pediatric Surgery and Pediatrics and our chief discussant for nicely dissecting in a, not in a pediatric way, but in an adult way in a surgical fashion, and made it possible, and that disease is totally cured to the 100% as far as this infant is concerned. And I congratulate on behalf of the Academy and ourselves, all the team. And it is ultimately the teamwork which made the baby to be seen like a normal, near normal and above normal. Thank you.